Anybody wants to, what were the problems? Like, I'll just give clues. Some form, there were large number of death until some main groundbreaking inventions were made and things like that. Any idea? Anybody wants to say something?
The cardiac problem?
Cardiac
diseases? Heart attack, like that.
No, that and all are recent problems. Thank you for answering. Like, see, infections, cholera, main problems were cholera, plague. There were different types of infections were the main issue. But today, is that the main problem? No. So today, what has happened? Today, as you said, what you said, this heart attack, all that, they are called as non-communicable disease. So basically, what I was telling, infection is communicable diseases. What was the problem before was communicable diseases, mainly like plague, cholera, those type of infections. So the current disease or the main problem what the whole world is facing is non-communicable diseases like diabetes, hypertension. You can add all what is given there: cancer, dementia, renal failure, heart failure, respiratory failure, all these. So these are all non-communicable diseases. NCD. You will all be seeing something called as NCD. What is it? It is non-communicable disease. That is increasing in large numbers. All of you know. See, nowadays you see diabetic patients diagnosed as diabetes. They are diabetic, type 2 diabetes, hypertension, stroke, heart failure. All these are different forms of non-communicable disease. And what is the rough figures, what the statistics gives is around 1.5 billion people with all these diseases. 1.5 billion people experience some form of suffering. It could be pain or different types of symptoms. And of that, the main 61 million are in 1.5 billion have the problem. 61 million end up, they have to undergo it without relief. So these are very big numbers. So this is one of the need. So if so many people are suffering, and what did I say? The first main pallium is to relieve or mitigate suffering. So because the demand is there in such large number, there is a need for long-term care. Okay. So, and then the next point is also equally important. See, there for any disease, we can treat to some extent. There may be a state where we may be unable to cure the disease. At that stage, death becomes inevitable. But in today's world, what we have improved is something called as quality of life. So we want to have a better quality of life until someone dies. So till the last breath, everyone should get best quality of life. So that is why the importance of palliative care. The need or demand is there. Large number of non-communicable disease patients are there who need or who are going through long-term suffering. So to alleviate their suffering, we need some form of care, and palliative care will be one such thing which will be beneficial. So that what? By doing or caring these patients, you can decrease the burden of the disease for the whole world. If each person is taken care of, the burden of the whole world, the society, community, everything can come down. Next slide, please. So coming now, what are the things? Like why? As I said, we saw in the previous slide, what is the need? Next, so what is that we're going to try? We will try to give active total care of patients whose disease is incurable and control their symptoms. So first we saw, if it is curable, we are going to give treatment and get cured. If it is not curable, then they also need some form of management. Next is they may have many symptoms which may not be covered under cure, but still they may have the symptoms. Those symptoms need to be relieved and give the best possible quality of life for the patient. And next, last point is equally important. It is not only the patient whom we are going to look after. the caregiver, because the caregiver also plays a big role. So we have to take care of the patient and the carer or the family too. So these are the core principles which we are going to have in mind. Next slide. So now comes the definition. This is quite a big definition. So that's why I've just highlighted the important type. Same what we saw in the previous thing. To improve quality of life of patients and their families. So in that we are including the caregiver also. Next, whom are we going to give? Whoever is facing challenges with, so what type? Life-threatening or life-limiting illness. So this is important. Life-threatening means, what does that convey? Life-limiting means what? Life-threatening means basically their life is in danger. For example, cancer. See, cancer patients may have a very short prognosticating time. Their life expectancy maybe, if they are in stage 4, 5, 3 months, 6 months, something like that. So that is life threatening. So life is in danger. Their duration of life may be shortened. Life limiting is a big group of people. For example, you can take dementia or end-stage renal disease, end-stage cardiac disease, end-stage respiratory disease. All those patients, they are unable to do what they were doing normally before because of the stage or progression of the disease where they've reached. They are unable to do what they. So that is life limiting. It is restricting their normal activity or limiting their normal routine. And it could be physical, psychological, social, or spiritual. It could be any type. We will see more about it as we go through. Because it is just not, for example, if someone has pain, it is just not the pain alone. Other factors may also be contributing to the pain. So we will have to cover all the 4 aspects which are given. And finally, the quality of life of caregivers improves. That also is important. So by taking care of the patient and family, we are able to improve quality of life of the patient and quality of life of the caregiver also. So this is the nutshell definition. So there are various aspects in this to say, and we need to cover all of them, giving equal importance to everything. Next slide. See, in this picture, you have the patient. Okay, the patient is having some form of disease. Okay, he is in pain, agony, discomfort, all is there. See this right side of the picture. Is it just him only suffering? Or see the caregiver, she may not be having the disease per se, but being a caregiver, it is her beloved. Could be husband, father, son, daughter, anyone it could be. So the physical problem may be for one person, but the carer, the family, everyone goes through the suffering all through. So this is something to be kept in mind. So when you see someone having a disease or difficulty or either life-threatening or life-limiting illness, it is just not the person alone. It is the whole family who all go through with it. So this is something to be kept in mind, that whenever we think of someone having problem, it is the whole family or the carer. It could be one person or 3, 4 people. So you have to have in mind, you have to include the family also when you are seeing a patient. Next slide. Little bit of history about palliative care. How did it come about? Dame Cicely Saunders is the person who is the founder, or who is the person who started this whole palliative care. She was basically a nurse initially. And in the 1950s itself, she started taking care of dying patients. But she had a lot of difficulties. She had to face so much of hardship. Everyone didn't believe and accept whatever her ideas were. So she got to a stage where she couldn't succeed. Okay, then what did she do? She didn't give up. She learned, she studied, and she herself became a doctor. And then she started looking after patients, and she started initiating palliative care services. She is basically from the United Kingdom. Then what? Afterwards, a famous psychiatrist called Dr. Elizabeth Kubler-Ross from America. She wrote a book on death and dying. That also initially was not accepted, but she wrote it in such a way which made everyone read the book. So, and she has also done not only that book, she is one of the person who has staged or defined the various stages of grief. So like that, she has done a lot of work on death and dying, grief, how to manage patients in end of life. All those things was done by her. Then afterwards, a surgeon from Canada, he coined the word palliative care. And then in early 2000, palliative care was accepted as a specialty. And in the United States of America initially in 2006, and then in the last 5 to 10 years or so, there in India also, see, both for medical students and for nursing, in the last 1 to 2 years, palliative care has become part of the syllabus also in nursing and in medicine. Similarly, all over India, there are so many institutions and facilities available for people to do palliative care as a specialty. Like you have a cardiologist, neurologist, everything. There is MD palliative care for doctors. There is the curriculum for nursing curriculum. They've included palliative care so that everyone is aware of it. So that in due course to integrate, to make palliative care also as one of the specialty in any medical college or in any institution. That is the aim. Because everyone needs to know about palliative care, be aware of it, and work together. So that is the main aim. Next slide. So that is how palliative care services started, and they have reached to where they are, and it will be constantly evolving process. Next slide here. So next we come to the next slide. These are the important. Is palliative care only for cancer and AIDS? You can all answer in the chat box. Is this only for cancer and AIDS? Answer in the chat box or unmute and say. So yes, thank you. Payal says no. How many no's are coming? Anyone says it's only for cancer and AIDS? Is there anyone telling that it is yes? Okay, glad. At least everyone is in the same idea that no, it is just not only for cancer and AIDS. Next slide. Next, is this only for end-of-life care? Is it? Do you think that palliative care is only for end-of-life care? No, that's all. So thank you, everyone. So it is just not only for end-of-life care. We will see what all is to be covered in due course. But because these two things, generally, broadly speaking, you speak to anyone, even our own professionals feel that palliative care is only for end-of-life care, or it is only for cancer, or it is only for AIDS. Unfortunately, it is not so. Next slide. Next, where can we do palliative care? So where all can palliative care be provided? So broadly speaking, if you see, it could be either hospital-based care or home-based care. Both can be done. It's not that only one is possible. Both are possible. In fact, we will say both are equally needed. Okay, but depending on what type of or what stage of the disease the patient is. Sometimes for some treatment, they may have to come into hospital. Sometimes they may be in a stage where they cannot come into hospital, where they will need home care. Okay, so this again, both have their plus and minus. Next slide. Okay, so next is as I said, both by providing home care, there is some benefit. By having hospital-based service also, there is some benefit. So what are they? We'll broadly see. What are the benefits of home care? Someone wants to say?
Please unmute yourself and talk.
Anyone can speak if whoever wants to speak. One clue is there in the slide itself. Okay. The main thing is that someone wants to say?
We can analyze the patient's family and their environment and their family socioeconomic status if you're going directly to the home.
Exactly. Thank you, Sundaravalli. Exactly. That's what. See, because many times we assume, and because don't think the patient alone, even when we go see someone, will we open up and tell everything? No, we are all normal human beings. Why on earth I should tell everything? That's how we feel. Even if it is good, bad, whatever it is. So, as Sundaravalli said, no, by going to the home of the patient, first thing is that the patient may be in a state where they cannot come. They may be bedbound. And sometimes you see in these pictures, they may be in places where access is in such a state, they cannot transport the patient from that place to the hospital. Nowadays, so many are in 10th floor, 15th floor. If they have lift, okay. If they are in second, third floor, no lift. So practical problems, many things may be there. So next, they may not have sufficient manpower to bring the patient. The patient and wife may be there. Wife may be the breadwinner. Wife may be doing everything for that person. But unfortunately, she has to go earn also. Otherwise, how will they live? So, like taking the service to the patient's home gives benefit for the patient. We'll see a bit more in detail. So, mainly logistics, or they can't come. Their economic status may be in that state that they are unable to shift, or patient is in a condition where a patient is unable to move. No, all these things to be kept in mind. So, by taking the service to the home, you are able to provide best service and best quality of care. And doing something at home, you are empowering the carer to do many things, and the carer will maybe happy doing it for them. So by educating the carers and empowering the carers, the patient gets the benefit. And there is lot of psychological, financial benefits by providing home care, because the patient may be at their own house. Whatever their minimal earning can be used for looking after the patient rather than spending for transport. And by training and educating the carers, you can still provide the best care. Not to think that only in the hospital the patient will get good care. If the patient is at home, the same level or efficient service may not. That all is a myth again. If you train the carers, educate the carers, and teach them exactly what has to be done. For that, all the medical team, the doctor and the nurse, may have to spend time and do that for the family, and they may get the best out of that also. So there are large amount of positive benefits by providing home care service. Next slide, please. So one more thing regarding the previous one is that, just we'll go back to the previous slide, Arya. By like the thing is that when you do hospital care, there are benefits for hospital care also. In that, what they are means basically under one roof, everything will be there. So if you go to hospital, you may be able to see the doctor, the psychologist, the physiotherapist. So under one roof, you're getting all services, and some procedures which cannot be done at home could be managed and done. So it depends on what. So that is why seeing the patient and analyzing what is the need of the patient, which can be done where. So that way, both have their own plus and minus. Not to say that only one type of service is best or one type of service is what will be beneficial. Nothing like that. So all those things have to be given importance and to be considered. So hospital care, as I said, everything are available under one roof, and patient like the psychologist, social worker, everyone. See, for example, in a home care also, if you organize and do, you can provide. That is where Pallium excels. Okay, Pallium has the capacity of having all these providers, and they will organize the home visit according to the need. Okay, patient X needs a doctor, so they will have a team with doctor. Patient Y needs a physiotherapist. That's the main demand there, need there. So like that, if you have all the facilities, still home care also can give. But in one time providing everything may not be possible, because these are all practical difficulties which may be there. So those type of things can be avoided when hospital care is provided. Next slide, dear. Next, so for whom are we going to provide the service? So that is where we saw it will be both oncological palliative care and non-oncology. So basically, it's just not only for cancer or AIDS type of patient. Here, you can make a big classification. Under oncology, you will get all cancer patients. Under non-oncology, you can have all systems, from cardiovascular, respiratory, renal, neuro, all type of patients. I'll give some simple examples. Under neurology, you can get all forms of stroke, paraplegia, dementia, all those type of chronic long-term neurological diseases, patients all will come under that. Other cardiovascular, heart failure, severe heart failure, where they have got to a stage where doing their ADLs is very difficult. Even to walk and go to the toilet, they may be becoming breathless. So those type of severe heart failure. Then respiratory, COPD, interstitial lung disease, all those patients who have very end-stage disease. Again, they also will have breathlessness as one of their very common symptoms. Unable to speak, unable to eat on 24-hour oxygen. They all will come under. So like that, and then end-stage renal disease, patients on dialysis. So all these, so non-oncological palliative care is a big entity. So that is why the previous slide I had, is it only for cancer? See, again, that is a myth. Many people still, many of our professionals think palliative care only for cancer patients. But that is not the truth. Okay? That's why I'm trying to explain and tell all the examples also, so that you're aware of. And all of you may be seeing patients. Is anyone already working in palliative care? We have got, what, 26 participants. Yeah. Anyone already working in palliative care? If so, please.
No.
Sorry, dear. Type on your type. If you could type where you're working, dear. ASIA, right? Or inpatient unit in a hospice, Kasturiba Hospital. Where it is? Sevagram. Which place, dear? Okay, Mrs. Trivandrum. Okay. Okay, thank you. So, why I asked was because some people... Okay, thank you. So, because just to be aware, see, people who are working in palliative care will be knowing, because any type of end-stage disease, it's not necessarily end-stage disease alone. This neurological patients, large amount of patients are there. They are all having life-limiting illness, not life-threatening illness. Okay? Any serious health-related suffering, in the definition that also is mentioned, either serious, we saw life-limiting, life-restricting, life-threatening, or serious health-related suffering. That is also part of it. As I said, no long-term discomfort, long-term pain, long-term care, long-term suffering. Okay, so it is a very broad group. We have got both cancer patients and non-cancer patients, which for whom all this service is required. Next slide, please. So what are the principles? So now we know for whom, where can we give all that. Then what is that we're going to do? So main thing is symptom identification and management. So if you take any of the patient, for example, we'll take cancer patient, for them pain may be an important thing. If you take respiratory patient, breathlessness. So whatever is their symptom, what is that causing discomfort for them, identify the symptom and manage that symptom. For example, we'll take someone who's having breathlessness, serious like lung patient, chest patient. Now main only problem is breathlessness. So I can't even speak, I can't eat, I'm breathless and I'm needing oxygen all the time. So if you're going to do something and ease that breathlessness, and they are able to do their activities by themselves, are they not going to be happy? What is that they are looking for? They are looking for, many times they will be knowing, oh, my disease is in a state where cure is not possible now. But what I want now, I want some relief from my symptom. So identifying the symptom and managing that symptom, that is what they're asking. They know very well cure is not, they're not asking us to give cure. They want some ease. As I said, no, alleviate or relieve suffering. If you relieve the suffering, they will at least be able to do what many times, no, these respiratory patients are unable to eat, unable to speak. So if you identify the symptom and ease the symptom and manage the symptom, they have better quality of life. Okay. And next is disease correction to the extent possible. Whatever is possible. Sometimes even for cancer patients, cure for cancer not possible, but alleviating. If you have heard of palliative chemotherapy, palliative radiotherapy, palliative, what is it? By doing that, for example, we can take pain. They have pain, but they're having pain, for example, they've got a big tumor. It is pressing the nerve and causing. By giving palliative radiotherapy, the size of the tumor will come down. So the pressure on the nerve will come down and the pain will ease. So like that, disease correction to the extent possible to alleviate the symptom. Next, psychosocial assessment and management. As I said, no, the patient may be having the problem. You saw the wife is upset, the children are unable to go to school. I'll give a simple, small example of a case. 40-year-old male who is the breadwinner, who has one wife and two children. He's been diagnosed with cancer of the tongue. He's undergoing treatment. He had surgery and then afterwards radiotherapy. So because he's had the surgery and radiotherapy, he's unable to go to work. His wife was a housewife only. He has two children, one 10-year-old, another 2-year-old. The 10-year-old is going to school. So this father who was working and doing everything, now suddenly he can't go to work. He himself is sick. So his pain, all that will be there. And on top of that, he'll be worried how my family will eat, how my son will go to school, who will pay his fees, who will get food for the family. So they are also his problem. His pain and suffering will be there. This also will be going on constantly in his mind. Okay, so we have to find out how or what amount of support is possible for his other issues also. Next is, when the same person needs some end-of-life care, can that be provided? Those are the 2 points, hospice care and terminal care. So these are the main principles. This is what we are trying to see, how and where in each level can we help. Next slide. And these are the important things to be kept in mind. We are not going to neither hasten nor postpone death. That means what? We are not going to make the death happen soon, nor postpone death also. So both we are not doing by providing palliative care. This is something very important to be known, because this is again a myth everyone thinks. Okay, I'll repeat the first sentence: neither hasten nor postpone death. That means what? We are not going to delay death or make the death happen quickly. Both is not done by palliative care. What will happen naturally will only happen. We only relieve the symptom. Symptom management is what is done. So provide relief from pain and symptoms. Then integrate psychosocial and spiritual aspects of patient care. So it is just not the patient alone. So patient means the disease. Sorry, it's just not the disease alone. You will consider the person. For example, person A has diabetes. He also has pain, discomfort, depression, all that. So it is just not the disease. The next part, all what I explained, is the illness, what all are coming as a result of the disease. So we are going to try to integrate everything and provide best complete care. That is the important thing. Next slide. Next, affirms life and regards dying as a normal process. This one I'm going to ask one question. I don't think it's quite a harsh one. See, is there, whoever is born in this world has to die. Is there any other way out? If someone wants to type or unmute, you can say, no, very good, Preeti. So it's not that there's any other way out. Okay, because death is also a normal process. We may not be able to accept it at some stage of our life, but that is inevitable. We cannot avoid it. We may not be able to accept it, but can we avoid? Can say, no, I'm not going to die. I'm going to keep on living. Can anyone succeed in it? No, no one can. So just understanding and accepting it in a nice way. Not only for us, we have to enable others also to accept it. So what? Well, it affirms life. We give full importance and due regard for life and regards dying as a normal process. So I'm just not only explaining, we have to give support, offer support system for patient until death. See, many times cure may not be possible. Okay, they go see someone, they say this much can be done. But after this, cure cannot be done. So what we say, cure may not be possible always, but care can be provided always until death. So even when cure is not possible, you can say, okay, cure is not possible, but care can be provided in these ways. As we told in my previous thing, we will take care of all symptom management. We will see what type of social, psychosocial support we can give. We can try to see what other in your house, what all we can help you and guide you. For example, some patient is there who's lost stability. Parkinson's patient started off, he was okay. Suddenly, to walk inside the house itself, he's falling. So what all we can say, this towel rail, hand rail is there, where you put your towel. You can put that in the house on the side wall so that he can hold that and walk. Or provide a walker or give a tripod. So there are so many ways to support. Like that, you can make minor changes in his own house to make sure his life is better. Okay. And then last one, not only until the patient is alive, even when the patient passes away, providing this family with support and bereavement support, everything, that is also equally important. Next slide. Next is the important thing, when to provide palliative care, because we saw initially that end of life care alone is not palliative care. So this we will see, this is also equally important. I will be thinking everything I'm telling equally important. Yes, unfortunately, because it is important, I'm repeating the same thing. Next slide, please. See, this is what is to be taken. I would say in this whole 50 minutes, this one is the important thing. So all of you, please concentrate. So basically, if you see in this, that first green bit is screening. Someone is unwell. It can be anything there. Okay. So when they are unwell, they are going, I've been unwell for 2 months. So what do I start? I go start doing testing. This test, A test, B test, umpteen test done. Okay. Then that green bit is testing. Then comes diagnosis. Okay. When you see the diagnosis point there, the vertical line is one thing, and then you have the horizontal thing going as course of illness. For example, at one point, some diagnosis is made. For simple reason, I'm going to take cancer as the diagnosis, because okay, cancer is the diagnosis. See, you see a yellow bit there. So immediately what will happen? Okay, this is what has been diagnosed. What all treatment can be given? We can start chemotherapy, we can start radiotherapy, or maybe we'll do surgery also. Okay, all that is done. So that is curative care. We are trying to see how can I cure the disease. So at that point itself, you see blue is palliative care, yellow is curative care. Even at the point of diagnosis, a patient this palliative care and curative care can work together. How you have main part is curative care. That is what is being given. And like, for example, when they are having chemotherapy, radiotherapy and all, you would have all seen patients who will have lot of pain. And the main oncologist will be treating and looking after the treatment part of it. They may not have time to manage pain and other things. So, and they may not have expertise also. So, if the palliative care team also works together, then active disease directed treatment is given. They are treating the disease. But when palliative care and curative care work together, they can give chemotherapy, radiotherapy. The palliative care team can look after other symptoms. It is just not only pain. You would all be seeing, as you all see palliative care patients, they'll have constant vomiting, constipation, fatigue. They are unable to do anything. They need what all they were doing by themselves. Now they need one carer to be with them. They're able to do everything only with support. Okay. So that time when they work together, so it can be. So, and as the time goes, they give all treatment. If everything works and the patient is getting cured, God's grace, very good. Let them improve. But unfortunately, they try everything, but the disease progression increases and the patient is not getting better. So what happens? See, the yellow part comes down. The curative care they're giving, but that's not helpful. So that is when the palliative care role increases. So see, first thing it says active disease directed therapy. This active disease directed therapy was carrying on, but unfortunately no good progress. So they get to a stage where they say, no, all this chemotherapy we tried, not helpful. So only palliative chemo we can give now. So that is when the palliative care role, the blue role increases. Okay. And finally, they may get to a stage where they'll say they are unable to give anything. This much only we can do. So that is when the palliative care team should chip in more and say, no problem, we can help you. We will manage as it goes. Today you're having vomiting. So, okay, that we'll see. And then slowly we will have to start anticipating what all can happen. When this disease progression is going to increase, the patient will move on slowly to terminal illness and end of life. So slowly you warn the family and the patient depending on what stage they are, and then it moves on to end of life care. So if the palliative care team was going hand in hand from the beginning, you will have better rapport with the family, better rapport with the patient, and continuous care you're able to provide. So you will be able to provide care even till end of life and after bereavement. So this is the important thing to be kept in mind. So working together as a team will be very, very helpful in providing the best care for the patient. See, for all of us, doctor, nurse, physiotherapist, psychologist, who is the core center for us? Patient is our center. So we are doing everything in patient's best interest. We are not doing anything in our best interest. Okay, be very, very clear. I'm doing everything in patient's best interest. I want the patient to get the benefit. So the same thing is what you should do, and try to provide the best care for the patient. Any doubt in this, please do ask. Okay, if no doubt, I will move forward. Anybody wants to ask me anything, or do you want me to tell anything again? Or is it clear? Okay, thank you. The next slide, please. So this is what as I said, no, suffering as such can be of all, suffering can have all these components. Physical is pain, breathlessness, vomiting, diarrhea, constipation, all those things. Emotional, I'm very upset, low in mood, being low in mood. That is also equally important because they cannot express. Okay. Then psychosocial. As I said, that we'll go back to that case, what I said. Sorry, we'll go back to the patient whom I said, who has, who is the breadwinner, who has a family, he is supporting family. So for him, is pain and discomfort only problem? No, how will my family live and eat? Who will provide them every month supply for to making food? Or who will pay my son's fees? Who will look after my young 2-year-old child? So they are all the psychosocial suffering. And last but not the least, everyone has a feeling. What wrong did I do to go through all this? Why me? I did everything right, but I am suffering now. Whether I did everything right, wrong, and all is individual. And we should never judge or assess or pass any comment to anyone of that type. You did that before, that's why this guilt feeling and victimizing, all that is not to be done, and this is not the time to do all that. So all these suffering can be of all these components. So that's why, as I said, we have to see, for example, someone has very severe pain. Okay, you give pain medicine, you've gone up to morphine also, but no pain relief at all. Then you should really think there is something I am missing. So we normally give an example for this also. There was a patient whom they were seeing, exactly similar to the history that I said. And whatever medicine they gave, his pain, he was telling 8/10, 8/10. He was wondering what on earth is happening. Then the doctor, then he said, then they went and asked the patient. So normally we also ask, what is that? That is Dr. Rajagopal's golden statement. What is that is bothering you the most? If you ask that, they won't say pain at that point of time. He'll say, my main worry is how will my family survive? I know I will not live. So something like this happened. They have seen this was told by Dr. Rajagopal and team once. So what they were going again and again, it didn't improve. So they asked him, and he said, no, my main concern is my son. He is good. I can't pay his fee. So what they did, they got help of another NGO or they gave this educational support, and within 1 week, they made some arrangement for that paying fees for the child, and then 10 days later, the same team went and the same medicine, no medicine change they had done. So that day when they went and asked, he said, my pain score is 4/10. So what that psychosocial element had a big role in his pain. So again, I'm not telling that we need not give tablet. So don't mistake in any of these things. So you have to give equal importance for everything. All round. This is called as total care. Again, this was started by Dame Cicely Saunders. She's very well known for it. She says all these components have to be kept in mind whenever you're providing care. So total care is the goal. Okay. Next slide, please. Generally, pain and breathing difficulty are the two common symptoms experienced. We say about nearly 40 to 60% of patients will be coming with this. And opioids play a very important role in managing pain and also alleviating some symptoms like breathlessness. Because if these things are managed at an early stage and to relieve their suffering, is our duty. So by doing that, we alleviate the symptom and regain respect and dignity for the patient. So this I just brought up because this is one of the common symptoms you'll be seeing, and this is a very, very distressing symptom. And all of you know, even when we get a little bit of headache, are we okay? No. So one small headache upsets everything. So when patients are in a state like with cancer pain is really very, very uncomfortable. And similarly, breathlessness for a respiratory patient. So as I say, we cannot be judgmental. We can't say this is big, that is not big, nothing we should do. So, but we have to understand everything is big from patient's point of view. Okay, so this is one of the common things. So I just got that up so that to be aware of it. Next slide, please. So this is what I've said before itself. What are the benefits of hospital-based care? Next slide. Then home-based care. The chronic diseases where when you can provide that with a multidisciplinary, all what I've explained in detail before, I've put in this slide. So care, don't think that when you're providing home care, it is not in par with one receipt. It can be provided in par if you have a good multidisciplinary team and you are very organized. So you see what is the patient's need and then provide that service. Okay. Next slide. We'll see some of the importance. See, from patient's perspective and from carer's perspective, what are the benefits of home care? See, peace of mind. The patient is very happy. See, we are all happy at our home. Are we all happy? Will we be happy if you stay in a hospital? Even one day, nobody likes. Okay? So my home, my room, my bed is there for everyone. That is there for that person also. Okay? And always you want to be with your near and dear ones. And being at home, patient and person feel so much comfortable. Even sometimes they are scared being in hospital. What will happen? They'll do this, they'll do that. I don't want to go there. All those unwanted worries are taken off, and then they are having the family members with them. So they're comfortable being at home. These all from patient's point of view. From carer's point of view, they have, it is their loved one. I'm happy because I am able to do. If many times you see in ICU, they don't even allow you to go near the patient. Is that what you want? So all of you have to start thinking, what is that I want for myself? That is what I should provide for my person or patient whom I'm looking after. Will I have different level of standard and will I give different level of standard to my patient? No. So, and then next is physical, psychosocial, financial, all those also are managed in a better way. And by home-based care service, ensure continuity of care for patients. And as I said already, empowers the caregiver. And only for empowering caregiver, you may have to do some carer education and giving best cost-effective treatment. Financial saving will be to a very great extent. And in this whole course, you will be seeing we teach so many home remedies. Don't think it is. They are all equally efficient. Don't think home remedy is cheap, not to standard or anything. It is equivalent, for example, equivalent to what
Selvi.
they require. Something like that. Okay. Next slide.
எங்க இருக்க? அவ குமிஞ்சு நிக்கிறா, ஸ்டூடெண்ட் ஃபுல்லா திருத்தாரு எம்எஸ்சி.
Okay. Next is not only providing all this service. Next thing is that providing some form of rehabilitation also for them. This is also something to be kept in mind, because you have to see, as I've been always telling, the patient and the carer. So if it is life-threatening, then whoever is surviving, you have to teach them and make them self-sufficient. On the other hand, if it is a chronic, long-term disease, then also the person who has the disease itself can get an earning. All these type of things are done to a very great extent by Palliative. For that also, I'm going to give you a small example. There is a patient who is a paraplegia patient. Okay, he's now 34-year-old, I think, but he has been like this for last 6 years, following an accident. So now what he does is he makes umbrellas. Okay, not one or two. He makes umbrellas in all levels for from children up to like industry level. So Palliative has helped him to have an earning for himself. He works like 6 to 7 hours in a day. He works because he makes so much, so that he is getting an income for himself. So he will have better respect for himself. Others will respect him, and it builds his own confidence. And seeing that, many more patients who are like that also may think, oh, I need not be upset. I can also try something like that. So these are things like for setting up a shop, or again, this you have to see what the person or the patient wants. You cannot force, oh, you do this, do that. We can give suggestions. They have to pick. You can give 5-6 suggestions based on their efficiency. Some people are learned, so someone may know computer, so we can give some different suggestions. Some may have vocational skills, so what is that they like and what they want to do, accordingly guiding and getting them to a track which is beneficial for them. Okay, next slide. See, why we tell all this is for you to start thinking in different angles. Next slide, dear. Arya, can I have the next slide? Thank you. So now this slide is important. See, all of you have joined this course as a nurse, but you all have other roles also. So what are all the roles that a nurse can do in palliative care? You can be a health educator also. As I said, we are going to do carer education. Then you could be a counselor just by talking. Many times, many families and people feel nobody comes and talks to them. Nobody has come to my house for last 2 years. I am just by myself. These are things all of you here. I'm just openly telling. Most of you will be seeing all this. So you could play a role of a counselor. You can be a messenger carrying information from them to the NGO or someone and helping them. And how you could train and teach them, and you yourself could be a caregiver for them. And finally, you could be an advocate for the person. Whatever they are suffering, you could raise your voice and try to solve what is possible at what level you could do. I'm not asking you, all of you, to go and do something and bring harm or discomfort to all of you. But try, don't hesitate, but try and think, and there's a possibility that all these roles can also be done. Okay, next slide. I think that's the final. Yes, thank you very much. I'm happy to take questions. And either any of you want to unmute and ask, or anything that you heard was not clear or anything like that, please go ahead.
Sundarivalli, are you telling us something? Please unmute yourself and talk.
Excuse me, ma'am. In the role of nurse in palliative care, there is a messenger role. In messenger role, what they will do, ma'am?
See, messenger role is basically, see, for example, the patient, I'll again take the example of what the case that I gave. Okay. There, that person needed some financial, psychosocial, all support. Okay. Because he's having treatment, you're looking after. So you can see how, again, see all this, no, it depends on the palliative care setup where you are. That is why we generally say to even at the beginning level of starting, minimum 3 people are needed. Okay. Doctor, nurse, and a social worker. See, we all may have the good heart to do everything, but physically, is it possible? So as I said, that person needed some educational support. So you could be a messenger taking that to your social worker and telling that this person has a child for whom they may need some educational support, because suddenly he is not able to go to work, and his wife is also a housewife. She will also try going for job. But see, suddenly one person going for job, looking after the family, and that the child school fees, all of us know what are the fees and things in today's world. So if you have a social worker, you could be a messenger taking this information to social worker, and the social worker has to do the groundwork, has to find someone who will be able to see. Generally, this example what I give is, see, we have patients who need support. Okay. Today's world, there are so many NGOs, charity, individuals who want to help, but they don't know where to go and help. Is that true or not? There are so many, they say, we want to help, but we don't want to go and give because we don't know whether it will be used properly. I'm openly telling, these are the queries in many people's mind. So in those situations, you can find an NGO or a charity organization. All this is done by social worker, not by, you're a messenger just carrying the information to the social worker. And then the social worker does the job. And see, the demand is there, supply is there. So connecting the demand and supply, the beneficiary gets the benefit. So slowly, that's why you start these type of palliative care setup, and then either you can get these organizations to come to your institute once in a month, or if you have an effective social worker, they can play the role, do all these, because the social worker's job is that only. Okay, so please, better to ask your queries, because everyone will be thinking, oh, so many things they're telling, it's not possible by me. Similarly, psychosocial, psychological impact, no, you need a psychologist. Okay, psychologist or counselor you need, because initially they may be low mood, depression. If you don't treat it at that point, it will worsen. The patient may get very violent, or they may harm themselves or harm others. They are not doing that intentionally. It is the disease, suffering, which is transforming them. So there, the role of psychologist is very, very important. So that's why, see, first level we say doctor, nurse, social worker. Next step, psychologist, physiotherapist. So nutshell, palliative care is a multidisciplinary teamwork and multimodal management. I have to treat the patient of the physical symptoms like pain, breathlessness, vomiting, diarrhea, wound infection, sore. I can go on and on. So all that is physical. At the same time, I need some psychological support. I need some social worker support. So that's why you need a multidisciplinary team and multimodal management. The doctor will do the physical management. The social worker will do all the problems, what are there and how. And the psychologist will manage this psychological impact. So ultimately, patient gets total care and total benefit. That is the important. I don't think anything else is there in the chat box. They have, I've just been checking them as and when. Okay. Anybody else wants to ask anything or any doubt in the presentation or anything anybody has? If not, I will pass it on to Arya. You have a model case presentation, no? You have that?
Yes, ma'am. Yes, ma'am.
I think in that case, we'll go on with that, because this model case presentation is also important, because all of you will have to bring up cases appropriate to the topic of the day. So that, see, again, like Sundaravalli asked today, all of you will be having, see, again, one thing I'll tell you, don't think, oh, my problem, what I'm telling is very small. They will all think it's silly to us. Never ever have those type of things, okay? Because this is the platform to use to get all your queries answered, okay? Here we are all doctors and nurses. We are all helping you to avoid all these queries and provide a best service, okay? So try to bring up cases and things, and don't hesitate to ask any doubt. So with that, I'll hand over to you, Arya. Go ahead, Suja.
Sister Suja from Palliative India itself will explain the case to you. This is a model case, and you will get an idea about how to present the case in our further sessions. I invite Sister Suja for the case presentation. Mr. X, age 39 years of male, diagnosis traumatic quadriparesis with stage 4 pressure sore on sacral region and left gluteal region. Presenting complaints is constipation since 2 days, bed sore over sacral region and gluteal region, moderate pain over the hip region and urinary leakage. History of illness. He had history of fall while carrying weight followed by neck pain and weakness of both limbs, and was diagnosed with traumatic quadriparesis in August 2015. Admitted and got treatment from one of the government hospital and discharged after 1 month. After 6 months, he developed a bed sore over the sacral and gluteal region, stage 4, and the iron deficiency anemia. Admitted MCH, blood transfusion done, and referred to Palliative India for wound management. Present complaints. History of pain over the hip and wound site for more than 2 weeks. Pain over the hip region. The score is 5/10. Intermittent burning type of pain. Bilateral and wound site 4/10 is the score. Continuous throbbing type of pain. Constipation since 2 days. Disturbed sleeping pattern. Decreased oral intake and urinary leakage. Examination. Conscious and oriented. The temperature is 98 degrees Fahrenheit. Pulse 82 beats per minute. Respiration 20 breaths per minute. BP 120/70 mmHg. And system is within normal limits. The pressure of stage 4, exudate present, tunneling present, irregular in shape, for foul smelling. Treatment and significant investigations. The routine investigations done. The HB 10 gram, TC 34,000, and PET 80%, lymphocyte 80%, eosinophil 2%, platelets 1.6 lakhs micro. Serum creatine 0.9 mg per dl, serum sodium 132 mg per dl, and potassium 4 mg per dl. Psychosocial and spiritual aspects. 39-year-old unmarried man living with his 65-year-old mother in a rented house. He has one sibling and he is married and living separately and not caring and helping them. He was a manual laborer and was the breadwinner of his family. Now his mother is a manual laborer and she is taking care of him. Now the main source of income is from mother's daily wage, her pension, and some of his friends. Have taken rupees 1.5 lakhs from private finance bank for the treatment purpose. Devoted Christian, now unable to go to church. This makes him very sad. He communicates through cell phone. He says to his mother, like, I don't think I can walk, so I can walk. So please don't spend money over my treatment. The medications, tab ferrous sulfate 200 mg BD and the tab folic acid 5 mg OD and a clean dressing with the nanosilver colloid mega heal ointment. Main concerns, pressure sore, pain and financial problems. Summary, 39-year-old man with traumatic artery paralysis with bed sore present over the sacral and left gluteal region, stage 4, with pain over the hip region. Discussion points is, do we need to provide palliative care for this patient? What are the problems faced by this patient? What all can be done for this patient and his mother?
We can ask them, and then we'll just give a thank you, Suja. See, just all of you know, you like this is just introduction only. But even with that, these are all common issues. So, what is that? Either you can unmute and say, or you can type of water. First thing, do you all need that? Do we need to provide palliative care for this patient? What is your thoughts? What do you all think? What are your thoughts? What do you all think? Few S's are coming. Okay, then next, what are the problems faced by this patient? Now you've heard for this 1 hour. What is that? What are the problems possible? And she gave a history of all. Just give few information on what's your take. How do you want to say? What are the problems faced by this patient? You can classify or tell in different ways, however you want. Pain, financial, spiritual, bed sore. Physical, psychosocial, spiritual, all 4 components are there. Okay. Wound is there, which is most bothering. Very good. See, at least you're all thinking in the different aspects. So it is just not one. So those are the problems faced by the patient. Then what can be done for this patient and mother? So just think and tell how can we help both the patients? Yeah, again, patient carer, we have been telling. So someone has said wound care and pain management. That is for to alleviate the physical symptom. What next? Addressing psychosocial need. Okay. Because he gave some statement, no? What did that patient say? So he's so upset and he's in very severe distress, dejected. So he is in need of psychosocial support. And one more thing I'm going to ask. The mother is the only carer. Okay. So if the mother is looking after him 365 days, what will happen to that mother? See, he is younger. Mother is 65-year-old. So what does the mother need there? Caregiver burnout. Very good. Who was that? Jennifer. We have to look into caregiver burden. So respite care. That is what is needed for the mother. Mother needs like 1 or 2 day break at least. She is only working, she is only looking after also. No? So really, caregiver burnout is very obviously happening there. Thank you very much. At least you've all been typing proper rest. Very good. Okay, dear. Suja, now I think you can go back and do what? Thank you for all your responses.
Ma'am, you want me to show the
Yes,
further
yes,
slides?
yes, yes, please.
Okay. Do we need to provide palliative care for this patient? Definitely, yes. As he is in a life-threatening situation, he has serious health-related suffering. His quality of life is definitely affected due to illness. Palliative care is not only for cancer, end-of-life situations. It applies to any health-related suffering, and that the above patient story is an example for this. Next, what are the problems faced by this patient? He has physical issues such as pain, bed sore, urinary leakage, insomnia, loss of appetite, etc. He has spiritual issues as mentioned in the presentation, feeling of being burdened to the caregiver, financial issues, identity issues, foul smelling wound over his body, social isolation, loss of independence, loss of job, anxiety, depression to be rolled out. What all can be done for this patient and his mother? Community mobilization for regular visits, fund generation is, if possible, vocational rehabilitation for the patient and mother, empowering the mother to take care of daily care for him, like position change, bed sore, dressing, etc. Any respite for the caregiver for few days. Look at the health issues and emotional issues of the caregiver. Make him feel that he is useful, convey that we are.
Thank you very much, Suja. See, exactly. See, what we discussed in, and then most of you gave all the, we can come out of this presentation, Arya. See, all of you gave the answers. See, that is why we say a good participation is needed, because, see, end of the day, all of you attend this course, you should get some benefit out of it, no? You should be effective, efficient care providers. That's the aim. See, one part is course. All of you think for yourself. Why have you all come for this course? Someone told you to come, or you also have the urge and need to do something and do something good for the society and for yourselves too. Okay? By providing and doing all this, ultimately, the person inside you is also going to be happy. Okay? So that's what every session you have to get. Attending the session itself is enough for your exam if you attend it properly. That's the important thing. Okay? So like that, see, most of the answers all of you gave. Okay? But we made it in a more nice way so that nothing is missed. So that's all. So this is the important take home, I would say, to understand why are we going to do it? What is the important thing? We shouldn't miss anything. And missing is not an issue. If you practice and do it properly, it will become like second nature. All of us learn to cycle once. You keep on learning to cycle. Once you learn, then 20th year, 40th year, 50th year, whenever you take a cycle, you will go on it. So the same thing, all of you learn and do everything in the best way you can. Then it will become second nature. Okay, so the main thing is that for you to know what is palliative care, what are the components of it, so in the rest of your 17 sessions, you will go in detail with everything. Then you can become masters for it. Anyone has any doubt, anything you want to ask, please do ask.
Please unmute yourself and you can clear your doubts. Or
That's
put
all.
it in the chat box.
Otherwise, whatever has been in the chat, we have covered. Okay, then in that case, I will hand it over to you, Arya. So the case presentation and things, they'll be you'll be informing them in the group whatever is needed. So this is a model, okay? What was done today is a model for all of you, so that appropriately, according to the session, what you're going to have, you have to bring up the case and case discussion. See, this case made you think, and also it gave you so many options. Oh, can I do something for the mother? Can I do vocational for the patient? Can I make him think that he is not useless? Okay, so all that. So like that, that's why case presentation is important. Will widen the knowledge for you in that particular topic. Okay, then over to you, Arya.
Okay, I'm really happy that our first session went on really well. Dr. Radha, as usual, your class was really nice. From the depth of my heart, I am thanking you. Participants were also very nice, very interactive and very attentive. I'm thanking all of you. Especially, I'm thanking Radha ma'am for the wonderful session, and she handled it really well without facilitator. She handled it really well. Thank you, ma'am. Thank you, everybody. As ma'am said, this was a model for case presentation. Case presentation is an opportunity to get familiarized with a patient who we don't know. We don't know in direct contact with. We don't know that patient, but it is an opportunity to get to know deeper to his clinical and psychosocial aspects. Thank you, everybody.
Thank you, Suja, too, for bringing up the case and presenting, so that it's a model, no, for them, so that they also need not be worried. You can bring up any case appropriate, what you've seen, what you have seen before, anything is okay. Okay. Thank you, one and all, and good luck and good wishes to all of you.